everybody. My name is Brittany Refutation, and today I will be refuting Andrea Hernandez's argument. My opponent's main claim was that assisted suicide has a positive effect on the clinically ill. Her secondary claims were, number one, assisted suicide will end the suffering of many ill patients, and number two, assisted suicide lessens the cost of medical care. I will be refuting these claims with two main points. Number one, many terminal ill patients don't qualify for physician-assisted suicide, and they still suffer, so therefore their suffering is somehow lesser than the suffering of the patients who do qualify. And number two, the money saved performing physician-assisted suicide is a really trivial amount, disproving the vitality of lessening the cost of medical care. So, first of all, my opponent's first secondary claim that assisted suicide will end the suffering of many ill patients does not cover those who do not qualify for assisted suicide. Although my opponent uses the qualifying term many and not all, by doing this, she assumes that the suffering of those who do not qualify is somehow lesser of the suffering of those who do qualify. Now, what does it take to qualify for physician-assisted suicide? Three of the main things are you have to be 18 or older, and you have to have less than 6 months to live, and then you have to be mentally capable to ask for your medication and to receive your medication. This excludes patients like newborn, and that's according to euthanasiaproandcon.org. But this excludes patients like newborns with terminal birth defects, minors with terminal cancer, patients with degenerative brain diseases, and the list goes on. So is their suffering somehow lesser than those who simply qualify? My opponent attempts to make an emotional appeal here, but she's also making the assumption that somehow another person's suffering is morality more just to end than the suffering of somebody else suffering the same, if not more, pain. Secondly, my opponent states that assisted suicide lessens the cost of medical care. She also states that it would save families money. And she doesn't give a specific source for this, but this is true. However, hospice, which is care for the terminally ill, can be covered by Medicare. And this is thus paid for by the government, therefore a family is not spending money. And although it's true the government is spending money on end-of-life care for patients, it would, if we were trying to save money and offered end-of-life care to everyone, it would only save approximately $10,000 per assisted suicide victim, for a total savings of approximately $627 million, according to Martin Levin, a special counsel for the Robert F. Kennedy Center for Justice and Human Rights. This is less than 1% of the amount that the United States spends on healthcare expenses. So overall, it's a really trivial amount if the government is trying to save money, if that's something that we're going to advocate for. And this claim is also true, and it's supported by another source, by Ezekiel Emanuel, who's an MD of the Chair of Department of Clinical Bioethics at the National Institutes of Health, and Margaret Batten, another MD, a distinguished professor of philosophy and adjunct professor of internal medicine, who say that physician-assisted suicide is not likely to save substantial amounts of money in absolute or relative terms, either for particular institutions or for the nation as a whole, in their 1998 article in the New England Journal. Yes, this article is from 1998, almost 20 years old. However, this shows that this problem has been the same over time. It was true in 1998, and it was true in Levin's article that was previously stated in 2012. So this, the costs have been staying the same over time. In conclusion, I have refuted my opponent's claim that assisted suicide has a positive effect on the clinically ill by identifying her assumption that it only helps some terminally ill patients and that the costs saved are trivial to the United States' overall healthcare expenses. Thus, assisted suicide only has a positive effect on those who qualify and only lessens the costs by a trivial amount. Thank you.
right, structural stuff is fine. At the beginning, you have a couple of counterclaims that you're laying out for us to go along with the advocate's claims. That might be a little bit... Sorry, there's a sneeze there somewhere. It's coming. There may be another one there. Thank you. Okay. I think I want to start with the second point first, because I think that's the point that you're clearest on and that your evidence has the best application to. The idea that you're going to save a lot of money suggests that, first, that there have to be a lot of people that would be available for that. I think that part of your first argument addresses this also. You mentioned two pieces of evidence. I think you want to switch them. It would make more sense to say, 20 years ago, here was the estimate. Today, here's the estimate about how much it is. And then I think you need one more piece of information, which is what the total spent on healthcare is. And you make it sound like less than 1%. My guess is that $627 million is far less than 1%. It wouldn't surprise me at all that we spend $1 trillion on healthcare related issues, and so less than $1 billion is going to be a tiny fraction of what we're talking about. And I think you could diminish it even more with that kind of argument. And I think that applies pretty well to the advocate. I mean, you don't really talk about their evidence or their reasoning, but you've got a very good counterclaim on that particular point. Now, the first point, I think, is a little problematic because you recognize yourself that at best you're diminishing the argument, and you kind of get a little bit into this value argument, like one group's suffering is less than another group's suffering. And that's not really the point that I think that the advocate's talking about. What I do think that you did a nice job trying to do is diminish how many people would have access to this, although I don't know what percentage of people with terminal illnesses are under 18 or under 6 months old or are mentally incompetent. Those, I think, are things that you need to provide a little bit of information on. Maybe you could look at some of the data from the states that have had this sort of thing and see how frequently it's used and suggest that that would be a way to indicate that it's really not all that significant or important or desirable. Like I said, I thought the second point was the one that you were the strongest on. All right, thank you.